For us, I think traditionally there has been silos. There were silos of mental health, there were silos of substance abuse, medical. I think when things really began to come together for us in terms of cultural shift was when we had to examine those assumptions and wonder whether or not they really do manifest in reality. When we think about our typical primary care patient and the comorbidities and co-occurring disorders that they have, you know, I think as professionals we had to ask ourselves, are we really going to ask our patient to go to 3 different providers, 3 different times in 3 different locations? And do we really think that we should inconvenience our patients who are already so challenged and fragile to navigate the system like this? No, I think we need to change. We need to start believing in integration, and that primary care providers need to understand mental health and substance abuse need to talk to each other or become one. And we also have seen North Baltimore Center's patients in Baltimore for many years. Through their care managers. They would walk them over and we would see them for their primary care needs. So I think we sensed that there was a very fragile, medically fragile population out there that wasn't being served at an extent that they should be served. So I think that's what inspired us to embark on this collaboration.
For the behavioral health side, I think one of the pushes was in the recent past when the feds came out with the outcomes that the mentally ill population is dying 25 years earlier than you or I or the other the norm population. So it was a push to really focus on total health and our patients' overall total health.
No, I think it was a proposal at first, and then we talked about it, and then it became kind of an interesting project. And we were just trying to figure out how we would really fit with this, since we were already integrated model, but then it became clear, well, this is about collaboration with a primary care health setting with a community-based mental health setting.
It was a tool that actually forced us, in a good way, to carry out the things that in the past the 2 facilities have tried to do. So it really enabled us to carry out and make sure it did happen.
Yeah, I think it formalized our collaboration and put some structure around it. And some actual outcomes to really look at.
Initially, I think it was really deciding even in our populations, who we were going to look at and how we were going to start with the referral. And initially from the behavioral health side, we actually had to change course because we weren't seeing the referrals. So we changed course and we focused on a population that people didn't have. I'm sorry, not population, but a service of population that they didn't have. So we weren't fighting over the same individual. The change, it was a lot of change.
There was a lot of teaching and coaching that you had to do. There was a lot of internal selling.
Yes, because you're asking an individual to take on the 15th task of their already, when they're already 5 tasks overloaded. So it was a lot of prodding and hand-holding and really trying to get them to see this is why, this is really going to benefit you. You already have to have these things. This is what's going to enable you to have, when I'm talking these things, their primary care. This is the first step to ensuring that you have that in your treatment planning. And I think really taking a step back and really looking at the piece, that you have this 10-step process, but to really focus on the first step and getting the first step down. So for us, it was the referral. From the behavioral health side, we referred 20 patients to the primary care. Of those 20 patients, 16 kept their first appointment, which 80% was actually higher than what we had expected. And of those patients, 2, we're not sure where the data is, but 13 of 14 had all the metabolics, the blood pressure, weight, the lipids, the glucose. And Dr. Chow can talk more about that in the comparison on the reverse.
We didn't do too well on the reverse. I think because our patients came to us knowing that we had mental health services, but when we discovered that their acuity was too high or their complexity was too high, and we knew where we needed to our services ended and North Baltimore began, we weren't successful communicating that to the patient. The patients didn't want to be referred. So the stigma of the specialty mental health, oh, I don't want to go there, I want to stay with you guys. And they were feeling like they were being dismissed or they were being discharged from our practice when really we were looking out for the best interests of the patient. We also discovered that when we have mental illness of a level of acuity that makes primary care providers panic a little bit, what our mental health staff was able to do in-house was just to kind of settle us down and say, no worries, let me take it, or we would be able to do a warm handhold to our internal mental health staff, who then was able to do try to do the warm handhold over to North Baltimore Center. But at the end of the day, it was the patient's choice as to where they wanted to stay. Pick off the low-hanging fruit to recognize successes. And for us, it was, knowing that our patient landed with you, or actually what was really, really satisfying was to see so many of your very sick patients land with us. So the connecting the dots part of it was a great outcome.
Sure.
We need to infiltrate North Baltimore Center with our staff in order to really demonstrate the collaboration and the willingness for our agency to provide services for you all. At the same time, we were having benefit because of other funding issues. So we were trying to do some Ryan White outreach and testing and counseling and education and all that good thing. So we were trying to do two things with one resource.
One of the things that having a primary care in our setting would be huge, because even though 16 of 20 go, there's so many more patients that we're not referring, even from our bigger population. So even if somebody comes in for a cold, and a lot of times they may have gone to the emergency room for that cold, so just being able to have them be referred to a physician who is just in our building, even not 2 miles away, even not even across the street, right upstairs, would help facilitate that. To start small, it's nice to have, a great idea, and to have, like these, that we could really impact this and really come up with some great things. But to start out small and work from there. Don't set your goals too high.
I think it's getting consensus on assumption, and the assumption and the vision being, what do we want to do to best serve our patients? And if that means that we need mental health partnership, well then how are we going to make that and operationalize that? So you don't artificially build a silo. You incorporate the mental health staff in your meetings. We have something that we call morning rounds or morning huddle, and it's a review of the schedule, it's a review of the patients that we're planning to see. And that's when we start doing the kind of the handoffs is, oh, Mr. Smith is coming in, and I think it would be great if you have time in your schedule to squeeze him in while he's here so that we don't have to have him come back. So it's that level of operationalizing integration that really helps to change culture. For the primary care side of it, this is a fragile population with multiple needs and multiple problems. And from our standpoint, to be in the same house where they're all there every day, the issue of having no-shows doesn't exist. You could just book patients one after the other, and if one doesn't show up, there's another one to take the place. So from an efficiency standpoint, the provider will always have patients to see. So rather than our expending all of these marketing dollars to, recruit patients, retain patients, we need to just partner with somebody who already has an existing population that needs us. So for HRSA to provide the change of scope for us to move in would be wonderful. And I think the barriers should be reduced for agencies to say, hey, we've identified an access point, a critical access point. Here's the data. Let's move. And really, I think the responsiveness should be, go for it.